Plymouth County Public Health Agency, growing healthy communities.
The beginning of this story is actually when we're trying to unravel from the overprescribing and the scourge of addiction and overdose. And the question that I had, which I think is all over your agenda, is what do we do about this? This is what everyone's been asking, right? What do we do? And the initial responses were, oh, we just need to stop prescribing opioids, right? That's a simple answer. The other one is, we just need to arrest people that are using drugs. The third one is, we don't have enough education. We just make guidelines and we hand them out to people and they're going to change their ways. Did any of those things make a difference? Do they make a difference today? No. I mean, how many webinars do you guys see coming across your email on a weekly basis about opioid overdoses, about treatment, opioid addiction, about pain management? They happen all the time. And I don't think there's a big benefit to a lot of what we're putting our effort into, and this was my concern early on. So we had to look at other ways. And I'll tell you, if you look at the evidence, there's only a few things that actually change behavior, particularly prescriber behavior, because that's what we're talking about, medical care. One of them is through formulary changes. That's kind of the heavy hammer. So if we cut off a drug from the formulary, it's harder, there's a bigger speed bump to cross in order to prescribe it. So that has an impact on prescribing. The other one, the one that I'm more interested in, is doing this one-on-one peer education, which is called academic detailing. And the literature on this goes back many decades, but the real origin comes from, does anybody know? Pharmaceutical detailing. Yeah. The way that we got here. And actually, there's an interesting story. Arthur Sackler, you guys familiar with the Sackler family? Arthur Sackler was the eldest brother, and he's a psychiatrist from New York, and this was back in the 60s. He got really interested into medical advertising. And he said, what if I advertise to physicians about drugs that my company makes? Will it change the way that they prescribe? And his drug was Valium, actually. He wanted to make Valium a household product. He wanted everybody to have it in their medicine cabinet. So he put advertisements in medical journals. He hired sales reps who did office visits, and he also did something else which we're familiar with, is he kind of blurred the lines about what this drug was good for. He made Valium good for everything under the sun. Psychic distress, for having too much housework. I mean, there's a lot of sexism actually in the early advertisements, in the way that it was done. But he looked to kind of expand the indications that this drug could be used for, and he developed what we know today as pharmaceutical detailing, which is, people walking into doctors' offices with donuts and telling them, how wonderful their kids look in the pictures and how they should prescribe their drug. And they walk in there with a lot of knowledge. They know about the prescribing behavior, they know about how they prescribe their competitor products, they know everything about them before they even show up there. So they have data and they have a one-on-one connection. So what Sackler did in the 60s with Valium really grew over time. And for his company, which was Purdue Frederick early on, became Purdue Pharma. After his death, actually, his younger brothers, Mortimer and Raymond, took over, and they brought OxyContin to market. So these early skills that he learned that were effective, not himself personally, but his company and his brothers used these techniques to promote OxyContin, a lot of the same ways. They blurred the indications on it, they used sales rep, they used data about high prescribers in communities, and they put some $200 million a year into their marketing effort, which was unheard of at the time. And did it work? Well, by 2010, OxyContin made up 30% of the market share of opioids in just 10 years. It was approved in 95, it was available in 96, and 10 years later, it was all over the place. So this was a very effective approach. If we look in the middle of this, 1960 to 2000s period of time, there was another physician named Jeffrey Avorn, and he saw the impact that sales reps had on prescribing, and he said, what if I can do something good with this evil? And he's really the grandfather of academic detailing, and he published his first study in 1983 about how we could change prescribing behavior with unbiased information being delivered in kind of a similar format. The difference is in academic detailing, it's peer-to-peer. You have pharmacists, nurses, other physicians. Obviously the sales reps are mostly with the business background. But he used the same techniques and said this is something that's effective. So that kind of brings us to today, when I come back to the question of how can we change this? How can we unravel from this mess that we're in? How can we stop people from dying? How can we do a better job of treating pain? How can we stop the suffering? And the answer is through these one-on-one contacts with people. So we developed a curriculum, an academic detailing curriculum. And I'm going to get too far off my slides if I keep talking.
Jeffrey, was it Avery?
Yeah.
Okay.
This is a quote from him, actually, and he basically said the same thing, that, you know, there's something poetic about using what drug companies did to get us in this mess, to get us out of it. He's very outspoken about this. He still is today. And he's published quite extensively on this area. But here's what it comes down to. Everything that I mentioned that doesn't work is what we do traditionally in academia. This is the way that we all learned. You sit in class and people talk to you, kind of like I'm talking to you now. You push information out and you hope people take it in. We use evidence, appropriately so, but we don't make it pretty. We don't make it digestible, and we don't make it patient-specific. You travel to meetings like this one, or you sit in class, or whatever the case may be, or you log into a webinar. And there's good information there, but the reception of it is not translated into change. So on the other side, when you look at pharmaceutical reps, they go out to the offices, they have the same evidence, it might be a little bit twisted, you know, because it's skewed to whatever they want it to say. And they have a one-on-one conversation. They have data about who you are, the patients that you see, and they talk about your patients specifically. There was a lawsuit actually recently in Montana. One of Purdue Pharma's drug reps, he wrote a deposition, this was just earlier this year, about what the company had him do in Montana. And there was a few things that were interesting. One is he had a list of all the high prescribers. So drug companies buy data from pharmacies, so they know pretty much all prescribing behavior. It's de-identified, but it's sold all over the place. So we knew who to go to, who were the high prescribers. And he also would call the office and say, hey, can you pick out some patients that might be appropriate for conversion to our product? You know, so chronic pain patients on opioids. So the office would have charts lined up for the physician, and he would talk about those specifically with them and say, hey, this is how you can get from here to there. All of these things work. If you use them for good, you can actually make a change in the right direction. And that's what academic detailing amounts to. And our project was based on that, is that we train people with all the information to walk into a clinic, to talk to physicians and other prescribers and pharmacists about their specific patients. So it's using all the same techniques, because that's the learning moment. It's like, this is the patient that I don't know what to do with. And you work through the problem for that individual. And there may be something more general as well. It's really very flexible in that regard. But that's really the impact of it, as opposed to, you know, here's the evidence that shows that you can lower the risk of a myocardial infarction in the next 10 years by using this drug. That's great. But what about, you know, Mrs. Jones that has diabetes and dyslipidemia, and she's been smoking 3 packs a day, and she won't take any of her medicines? How do I work with her? The detailing visit actually addresses her needs. It's not just this data that's being, you know, portrayed on the slide. So that's the difference between them. So you guys got a handle on what academic detailing is and kind of where it came from. Okay. So, like I said, we took this model and we applied it to opioid safety or opioid stewardship, which is what we're up against at the moment. And what you guys have probably been talking about all morning. And it took us about a year to put the curriculum together. And I got some of the materials here. You guys can take a look at them. You'll see something, unlike the black and white handouts that you get at most meetings or conferences, we have things that are pretty. They're not overloaded with data. They're visually engaging. They're simple. They're easy to retain the information. And I remember back when SSRIs were being brought to market left and right, just must have been 99, 2000. There was always these pretty graphs that would show the competitor, and there's a big arrow saying, how much better the response rate is with our drug. And you could see it from a mile away, what they were trying to tell you. And that's what these materials show. And I'll let you guys look through them. You can pass them around. But we had to work really hard to distill information around opioid safety to take-home points, whether it was around pain management or safe prescribing, use of buprenorphine, naloxone, whatever it might be. The information is, it's not overwhelming. There's 30 pages in each one of those, but they don't get into a lot of detail. You have to have very simple take-home messages that you can reference. So after a year or so of putting these together, we had our first training in Lake County, actually. So our approach was to hit the highest risk communities first, places that had the highest overdose rates. They were rural communities. We started with Humboldt, Lake, Plumas, Siskiyou. There's pretty much all northern California. Communities came into the early stages of this. And we had data on their prescribing. First go around was using Medi-Cal claims. After that, we went with Cures data. We were able to identify the high prescribers in the pharmacies that dispensed a lot of it. So the idea is that we have trained detailers that go into a community, and they can address both the prescribers and the pharmacists, who are seeing the same patients, and there's kind of this two-pronged approach. So in order to do that, we brought the detailers into these regional meetings, and we made them sit there for a day and a half and put up with us going through the curriculum. And obviously it wasn't didactic for those that have been to our trainings. It turns very quickly into a hot conversation because these are controversial topics, and that's great for retention. Things that make you emotional, you remember better. They're important to you. So, we have all kinds of different opinions around the table and some really fantastic representation from different disciplines. And we had very, lively discussions about these topics. So these materials we went through kind of cover to cover, but they were just a foundation for these conversations, which we're going to translate into what the detailers were going to be up against when they made their site visits. So they got to retain it, they got their questions answered, because they really had to be experts, and it's really hard to get somebody to be an expert in this area in a short period of time. I mean, that's a big challenge. For those of us that were doing the trainings, most of us have been doing this for 10, 15 years or more, addressing these specific issues. So a lot of our detailers were primary care doctors and community pharmacists and nurses and other people that were interested in this, but they didn't exactly have the expertise. So we had to cover all of the hot topics, all the controversies, and get them comfortable with the material in a short period of time. So the, let's see, I'll get to the agenda in a second, but here's an overview of where the trainings were. We've done 5 to date. Lake, Sacramento, San Francisco, San Diego, and most recently down in Los Angeles, we were in Burbank. And actually we had people travel from all over the state to each one of these. We tried to make them regional so that people close by could show up, but people were traveling just because of dates and convenience. So we had participation from many areas, and you can see the counties in orange were specifically represented, but the caveat is that we had a lot of regional representation as well, from health plans, from tribal health. There were some FQHC conglomerates in Southern California that had 25 clinics. So their medical leadership would show up at these. So I'm showing you counties, but the reality is that many of the detailers that we train spread across many counties, or their institutions spread across many counties. So the coverage is actually much greater than this. There's about 75 total detailers that have been through this so far. So it's only been a year and a half. It's still in its infancy, and frankly, as trainers, we're getting better at it. The materials are constantly being refined based on feedback and as data changes. So that's a work in progress, but so far it seems to be working quite well. And at the community level, this was a lot easier in the rural counties where we're able to say, here's your list, Dr. Satterfield, of 40 physicians. You might be on it. Go talk to your friends in your community and go talk to your pharmacist. On the back end, we'll be looking at what the community level impact is, and that's yet to be determined. But coming back to where I began this conversation, we have sweeping changes in opioid prescribing that are happening regardless. Over the last 4 years, our number of opioid prescriptions has dropped substantially, like 30–40%. And that's happening just because there's a lot of publicity on it. People are cracking down from every direction, whether it's a payer or the DEA or the medical board. There's a lot of scrutiny around this, which has an impact on that. But that's not a very good measure. That doesn't actually tell us if people are enjoying themselves, if they're alive, if their addiction's being treated, if their pain's being managed. That cutting opioid prescriptions is kind of a flimsy marker, so I don't think it's very useful. But what I do think is by having these one-on-one conversations, we can actually help our prescribers make conscious decisions about what happens to patients that are on high doses of opioids, or people that are showing up that are suffering from heroin addiction. And we can get those people into treatment. We can use alternatives for pain. And we can use opioids appropriately. And the next push on this, I'll tell you right now, is really going to be in the other direction. By policy, and even statute in some places, in other states, the day's supply in opioids for acute injuries is shrinking dramatically. It went from 7-day supply, and now it's down to a 3-day supply in some places. There's a cap on the number of morphine equivalents that you can get with your initial prescription. They're not allowing refills on them. And some of these are being done by pharmacy chains even. So that is really pushing us in the other direction, where your access to opioids for people that are in hospice care is being compromised. People that have had acute injuries are not getting adequate supply. And this is a real issue in a place like Quincy. If you live 35 miles outside of town and you just had knee surgery, are you going to make it back to get a new prescription or back to the pharmacy in 3 days? It's just not practical. So we really have to have a balance on this. It can't just be cut it off and everything's going to be fine, because we know that's not the case. So my guess is that future iterations of our detailing curriculum and these materials will probably have to put more emphasis on appropriate use of opioids, particularly around acute pain conditions and end-of-life care. So that's just my prediction going down the road. Anybody here want to be an academic detailer?
I'm doing it right
Yeah,
now.
we had a couple that are.
Yeah. It's very, very interesting.
You want to share what your experience has been like?
Well, I think it's brilliant. I think academic detailing is one of the keys that it's going to help us. It's a matter of education and being out there and having done over 25 sessions now, and what I really find is that sometimes I can go in and they're just being bullied by the patients sometimes, the PA or the nurse practitioner or the MD, and They just kind of need a backbone. They need somebody to say, I support you, and let me show you some tools for it, and ways to get through to titrate them, like naloxone, and what their kind of their rights are, you know, as a physician. I try to go in and empower them, and then I get the other end of it. They think they know everything. And so it's a hard balance sometimes. I have reached out many times to ask for help through the training program, and I have no problem with asking for help. I think that it's only going to make me a better academic detailer. But my personal experience is I do think it's the key, because if you can really gain the respect and the trust of the provider, I think that we can really help them, to empower them, to help the patients and not worry about only 3 days of opioids, or I'm just not going to prescribe anymore, which I hit up against a whole entire hospital system that won't do it. I do think that we should almost expand into like a Kaiser or a partnership, and be educating at the level of the people that are providing the insurance. Sometimes I've had this intuition hit, like, during it. I don't know, have you ever done academic detailing at that level?
Yeah. So the last 2 trainings that we did in Southern California had a large representation for medical plans and medical groups. The challenge is it doesn't necessarily trickle down as fast. So you like hit the ground running.
Yeah.
With doing visits. They're still talking about it up here, right? Because they have to get their workforce together, and they have to be strategic. So, you know, in your case, we said these are the people that you should go talk to. For the health plans, they get to pick out who it is. So they have to come up with their plan around who are we going to target, how are we going to make contact with them, and they're looking at ways of softening the approach, I think, because this is very resource intensive. You know, how long did it take you to do 25 visits?
5 months.
It's a lot of time that goes into the scheduling, the contact, the
Getting the
follow-up.
appointment can sometimes be the biggest part, especially with the doctors that know that they're prescribed, they're high prescribers. They're really hard to get that appointment.
Yeah, I bet. So the health plans, they weren't spoon-fed that information. We helped them with the guidance, but they have to come up with their own approach and what their objective is, you know. So it's going to take them some time to do it. I'm really glad that they're interested in doing this work, but I think there will be a delay. And we've had, you know, partnership has been represented at our training in Sacramento. So we do have interest. There will be movement on that front, but I think it's going to take some time for their game plan to get together.
You know, here in Plymouth County, we had so much interest in like getting better, because we actually, before statistics were even out there, we knew we had a big problem, and we knew who the people were. And one thing I wanted to speak to is the partnership between pharmacists and physicians and mid-levels has improved dramatically because of this, and other things, naloxone. It's fabulous. I mean, pharmacy keeps getting more and more complex, as does medicine. The fact that the partnership has improved between local pharmacists, so that's a huge plus. But I do understand that what happens to the pharmacists, they see a problem, they call the provider, and they get nowhere. This happens over and over. When you talk to, I had no idea, really, actually, personally, that they call the provider and they say, well, do you realize this person just got it filled from Dr. Smith down the road? And they're like, they can get nowhere on that. So it's really, that was a little bit of a wake-up call for me. And frankly, here, we had so much buy-in from providers that I really thought that, we've made big headway. We're down 61% in morphine milligram equivalents over 5 years. So that's nice improvement. But on the other hand, there was a death last year of somebody who was on 240 milligrams of oxycodone in the North County. And that's an individual that we didn't get to that provider in time. Actually, in detail now, but it's a good example of how you can provide all the education. We because of distance, because of denial, because of all the myriad of factors. And so fortunately that person's been detailed, but there's a death. So it is hyper complicated. Just to speak to one other physician-related thing, I came through training at a time when I didn't want to talk to detailers on any drugs. I thought, what patient wants their doctor making a decision about a drug based upon an advertisement in a journal or somebody who brings them trinkets? It doesn't make sense. But most doctors do see detailers. They're pleasant people to talk with. They're wonderful. They treat you like you're walking on water. And the evidence, even though you interview doctors, do you ever pay any attention to that detailing? Oh no. No, I never change my prescribing habits at all based upon what I'm told. That's just baloney, I just ignore it. The truth is, of course, we know it makes a huge impact. And there's plenty of evidence over whatever, 30 years more, that providers do pay a lot of attention to it. So we're coming to a great place here where this project is going to define how this can be done in the future. And for providers like myself who never saw any kind of detailer, we had to learn too. And it's great. So anyway, there's a couple thoughts from a physician perspective. I was quite the skeptic because the term detailer is a bad word for me. I'm serious. My nurse, I don't have to practice much anymore, but my nurse came up to me and said, hey, there's an academic detailer out here who wants to see you about the OxyContin you've been prescribing. No, I've got 3 people waiting. No way. You make appointments. I know it's not like that, but anyway, it's great, exciting work.
Well, and, we have to get past that, and I guess it's part of the reason I make it part of this conversation is that most people's experiences with pharmaceutical detailers, and that's the connotation around this.
It is.
And there's increasing resistance to it. Honestly, the way that pharmaceutical industry interacts with physicians today is far different from it was 15 years ago. You don't see many of those anymore. The gifting stop, the dinners, the trips to Hawaii.
I had the hot air balloon ride.
Did you?
Yeah, for Labor.
That's
Wow, that's
nice.
amazing.
Yeah, that was down in Temecula, though, over Hawaii.
You have that rep's name? I haven't.
That was a few years ago.
When I started with the San Francisco Department of Public Health, there was a sign-up sheet for drug companies to bring lunch into our clinics. And my secretary actually was organizing these for each of the clinics so that they had lunch, once a week, all year long. And it actually took me about 5 years to get everyone to think differently about it for the reasons that you brought up. The idea is that, hey, this doesn't have any impact on me. I'm just eating their food, and then, But I look around the clinics, and we had clipboards and pens and clocks, and I got patients standing on scales that are being handed out by Eli Lilly, who makes Zyprexa. You guys might know Zyprexa causes a lot of weight gain. It was all over the place. And the entry point was these lunches that the reps were bringing. And nobody even saw the impact that it had on prescribing. So there's a whole dirty backstory to this. So turning that into something positive, I'm really glad that we're able to. And I mean, frankly, I'll do anything that works, and this is a perfect example of it. So we're going to hopefully continue to offer these. I don't know what the schedule is moving forward, but you can see there's a lot of this state that we haven't covered yet. So we're going to continue to refine it, and we take feedback from our attendees very seriously to see if we can fine-tune the day and a half, because it's a lot that happens.
I think Cassie has detailed at least 6 or more people in our county and had a good experience. And, about half of them were people we knew. If you talk to the pharmacists, the others. But anyway, you mix it up so that people don't feel. You talk about stigma. We've been talking about stigma for all day, right? There's stigma about being academically detailed by somebody who is telling you might be prescribing too many opioids. But anyway, yes.
It's a delicate approach, when you're being targeted for that reason.
Yeah, but you've worked very, very hard to avoid that connotation. I think that's really definitely a credit to the way it's been done.
I think a lot of what we try to provide to the detailers is a way to soften this, because there's so many other explanations. I'll give you an example. I spend a little bit of my time at an FQHC in El Dorado County, and there was a previous generation of prescribers there who, you know, were on the opioid bandwagon, and they retired, moved away, you know, died in some cases. So it's the current generation that's just receiving these patients in droves, and I would hear names of the prior physicians. Oh, he would give me everything that I asked for, because I'm looking at, you know, 3 benzos, 2 opioids, and a stimulant, saying, how did this happen? And the patients, you know, really, I think, are fairly innocent in this, and they asked and got what they wanted, and they just kept moving forward, and these things build up over time. That's how polypharmacy happens. So we have a lot of new providers who are showing up, and guess what happens when you're the new provider? Your caseload's wide open, so all those people come to you. And when I look at their prescribing on paper, it looks like they're the highest prescriber in the county, possibly because they inherited the most patients from, you know, previous providers. So it's not always black and white. You know, when you're making that visit, it's not like, you know, Dr. Satterfield, you're a bad doctor because of all these opioids. It might be, well, you're the only physician in town that, you know, sees these patients, or you inherited the caseload.
We've seen those transitions here for sure.
And really something that we have to bring across in our detailing visits is empathy. And this is true for any consultation service, and detailing is in some ways a consultation. The first thing you have to do is help the provider, because everyone's struggling. You know, everyone's frustrated, they're scared, and there's a lot of push coming, you know, from different angles. It's either being pushed at them from regulatory bodies to not prescribe. The patients are saying, give me more, I'm suffering, and they feel torn, they don't know what to do. So empathy goes a long way to say, hey, I get it, this is really tough on you. I'm here to support you. And in many ways, the curriculum is designed to help our detailers meet the needs of the people that they're meeting with. You might have an agenda when you show up, but you probably have to let go of it pretty quickly and say, what is it that's, you know, where can I help you? Where can I help your practice? What can we do different here? So it becomes a very tailored conversation, and I think it helps with some of the stigma and the sense that you're under attack.
Those people lived it. They may not realize too. Nowadays in modern healthcare, employment is based upon your satisfaction surveys, and you know there is a way. It's been shown. I know there's good literature out there that if the provider takes the time with the patient to discuss what's going on and why they think that maybe we need to not add that medicine, or maybe it's well received. There are no ill satisfaction, but the common knowledge amongst providers is that if you deny people their oxycodone, they're going to complain. And actually, the Portola Hospital down the road, I was talking to one of their people just last week in anticipation of our meetings here, and he said, yeah, we knew that was going to happen. When we started in 2012, started cutting people back, tapering people off of things, we anticipated, we had the board of directors of the hospital on board, administration on board, several champion providers knew this had to happen for safety and for better care. But we were prepared for the complaints, and he just told me the other day, he said, every day, in this little tiny town down the road from here, they had another complaint about another provider. And so providers are afraid of that. They feel boxed in, you know, I'm going to lose my job because I'm not. Another part that I may mention tomorrow, but that I think is often not thought of, is we're so often treating our neighbor, our kid's soccer coach, our spouse's boss at work. Yeah, I mean, and you talk about kind of a certain amount of undercurrent of pressure. These are the people we see every day, and then they give us a story like, well, you know, when you cut me back on the Percocets to 3 instead of 4 a day, I couldn't get myself out of bed in the morning. I couldn't get the kids to school. I couldn't do this. You know, it goes on. You know, anybody's done the counseling or worked in primary care, and you know that's and especially when they're your neighbor, or yeah. So we have to get past all the. We're being paid, right? We're the ones who are supposed to be professional. They're, you know, and we're supposed to bring our expertise to help them. And so now we have the tools, partly by virtue of CDC and academic detailing and other reasons, have the tools to understand opioid hypogenesis syndrome, and to have those people that we've tapered that are so relieved to not be taking those pills every day and feel so great. But you know, we can get lit up as a provider. I get lit up with that because I meet those people at the detail. I don't know when you get the chance, but it's powerful stuff when you can look the person in the eyeball and say, you know what, Charlie, I know you feel like you're going to be worse and it may be a little bit rough for a while, but we're going to get to a much better place for you and safer, blah, 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 you know. But it takes time. You got people, you're running 40 minutes late for clinic, so that's where Dr. Gasper comes in at El Dorado. It's like, well, I want you to see Dr. Yeah, so anyway, I always love my 2 cents on this. We've been pretty successful with grand rounds, but part of it is we had a very receptive medical staff that were on board with the idea that there was only a small number. So yeah, we've had the retirements, we've had people move away, deaths, saying a couple of DEA sanctions, but by and large, the momentum in our county was in favor of improving. And like I say, we did have a death last year of someone I know that all I have to do is the death check cures and see where it's going from.
You know, it's some of these things that I kind of discounted early on, I will tell you, have a different impact in a small community. When the social pressure is to change based on a guideline, there's a level of accountability, and everybody wants to conform. You don't want to be the outlier, and that does have an impact. And there's places like Kaiser that use this. You know, they have report cards. So Kaiser and the field have had academic detailing for decades, and one of their approaches is they'll basically put together a report card.
Yeah.
And they'll come and say, Dr. Satterfield, you're under prescribing beta blockers for your patients after a heart attack. You're only doing 20%. Dr. Jones next door, he's at 80%. So you might want to get on board here. And this kind of dynamic does work. You know, it's like this is what your peers are doing, and you're not fitting in, especially in a tight-knit community, whether it's a health system or a community, where it's like everyone else is doing this, you probably want to get on board too. So there are other ways to get from here to there depending on your setting. And I think you guys are fortunate in that regard that you have a close...
In many ways, but, we did have a provider, I'm not going to mention the community because people will know who this is, but we did have a provider, no, they haven't been there for 5 years, but we would see the overdose in the ER, near fatal, and we would call that provider, or we'd see their patient and they're in here for a sore toe or something, and they're on diet, Dilaudid, plus they're on some benzo, plus they're on soma, and all that. They're somnolent and can hardly talk to you because they're so stoned out. We would call that provider and, oh doctor, nobody else taking care of this person's pain. I'm the only one in the county that will do for this person what they need. And he'd say, well, they're only 30 years old and they're just complaining to their backs, lots of back, there's better treatment. Well, and there'd be no communication would die. This person was ultimately sent to the DEA because for whatever obvious reasons. And then, just to add to what you're all talking about, is when that person left the community 5 years ago, a family nurse practitioner had to pick up all those patients. And unfortunately, none of us, when we come out of training, are probably really ready to deal with this. And there's all these interesting dynamics that go into somebody my age who's male. It's easier for me to convince a 45-year-old guy, than it is, sadly, I'm not justifying that, but we know that this is a reality. Somebody that's just out of PA school who's 25 and female is going to have less luck and not feel empowered in our society. So I'm sorry to drag gender into this, but you can see part, I don't mean to condone that, but that's some of the reality we all deal with.
Yeah, be real about it.
There are real issues. There are.
Yeah.
And, to your point, using good cop, bad cop can make a big difference. And I don't like being the bad cop, but sometimes that's my job.
Yeah. Yeah.
And
can I refer patients on the
But these are all things that, I think we have to leverage at the community level is, who can make the changes, and you also know who's not going to make any changes just based on their history.
It's frustrating. One, we have, well, it's just, a person who's prescribing heavily, but maybe nearing retirement, may not get detailed, because the assumption can get made that that person, it's not going to be long, it'll be out of 50 minutes, and then they don't retire. Yeah, could be a problem.
Running
But I
out
will
of
say, another advantage here in our county is that all the providers work for a healthcare organization like a district hospital with its associated rural health plan. That's true in Plymouth County. It's less true in Lassen, although Lassen has done a good job of decreasing prescribing. MODOC, everybody works, for a clinic, or, and that oversight makes a difference too. When you've got a board of directors and you have, one of the problems in Lassen, for example, in Northeast, also they have so much change in administrative people. Their medical director will change every 6 months, administrator change every 6 months. It's hard to get track.
That's a hard one.
Hard to
They're
get track.
constantly changing,
And it's constantly changing, and by the time you make the connection,
especially in a small.
It's a tough area where we can see progress.
question in the back.
I did have a question. So going off of that, we've kind of inherited the last generation of overprescribing. What is the conversation like with those people now moving forward with that, with their treatment plan?
With those patients?
Yeah, with those patients that are on so much, how are we dealing
Yeah.
with them now moving forward to decrease their usage or fix?
I'll tell you, I get a lot of these shunted to me. And this is usually goes something like this. This is what's been going on, and we're going to continue it. Don't worry about that. But things are changing, and this is what it's going to look like moving forward. And these are what our choices are, and what my concerns are. So you begin the conversation, very softly, because what usually happens, and this is commonplace. You get to see your new provider, and they're like, "I'm not doing that," and the patient goes running away, right? And we can't lose patients.
Right.
We need to engage them, right?
And they convert to heroin when they don't get their pills.
Unfortunately, there's more dangerous drugs out there.
Right.
So the first conversation is, "You're my patient. I'm going to take care of you. This has been going on." We have to realize that A, getting to zero is not realistic, and B, we're not going to get there overnight. And you have to tell patients that, and you sit with them through this process. And you say, "I'm going to work on your depression, your anxiety, other ways of managing your pain. And we're going to do this very slowly, and you're going to have a lot of choices." It doesn't have to be every month I'm going to drop your opioid dose by 10%. Maybe next month we work on discontinuing your Ambien or cutting back on one of your benzodiazepines. It's up to you. And when life isn't going well, we kind of pause. And then we go back to it. So we have realistic outcomes, and we don't try to get to them immediately. And for somebody that inherited that patient, if you document that you're making progress and this is your plan, and you offered them naloxone, and you're doing all these other things, I think you're in a pretty good place. I mean, documentation is very important under those circumstances. But the knee-jerk reaction is, "There's no way I'm doing that." It's not going to work. You're going to lose patients. They're going to go somewhere else. They're going to end up getting it, and they're probably not going to get the care that you would have offered them under those circumstances. So that specific circumstance, when you look at it on a patient-by-patient basis, is what I think academic detailing is designed to address. It's to say, so what about this patient who's scaring you with the number of drugs that he's on? How can I help you make those decisions? And I'm going to come back and see if they worked and what our follow-up plan is. Because that's the kind of help that you need. And you don't get that from a webinar or from a PowerPoint presentation or from some guideline. It doesn't tell you what to do with that person. So.
And I can't say that I've seen the physicians come, or the providers, come out compassionately like that. I would say it's around 50-50. Around 50-50, they want to get it off their plate sometimes.
Right.
They're kind of forcing the doses down. And that is a difficult thing, even though you can come in softly as a detailer and say, that's kind of shown not to be, a good way to do it. And maybe if you could try to work on a team approach. And, but they just want to get it off their plate sometimes, and that becomes difficult.
And so much is about control, right? When you give the patient
Yes.
control and they understand that you want to share that decision-making, let's find a solution. There's so much, it really empowers them, and they immediately feel better. Their anxiety drops. I'm fortunate to work in an environment. We have a very slow little ER over here where I work. We see 13 patients a day. So not infrequently, if I'm seeing somebody in chronic pain, I have time, I can sit with them. And now it's a complete luxury, because if you're working for Kaiser or whatever, you got to see 20-something a day, it's tough, much tougher, and you need your priority, right? But if your priority is right, because this person is important, they're paying for the visit just like everybody. But it's emotionally draining to work with these people, and if you're out here in the boondocks, we get somebody delivers a 28-week baby last night at 2 a.m. and we had to transfer them to Sacramento, and that's another factor of rural medicine often, you're emotionally drained in ways that maybe if you're just in a clinic, you have no hospital work, you come to the clinic every day. Yes.
It is very emotionally taxing, and that's why I think the empathy and the support is important. So you have to share some of that burden.
Absolutely. It's so important, the work, the academic detailing. It's just a little thing like a provider saying to you, well, when I brought up buprenorphine, they immediately said, well, that's for heroin addicts. And how do I deal with that? How do I talk to my patient? I think that's one of the biggest obstacles I see for the providers is how to speak to the patients in 10 minutes or less.
Right.
Well, do you think that it's not enough providers? Do you think that maybe that's one of the reason they're trying to just push people out so quickly? Do you think that's where the fall through is, and why they're not having those sit-down conversations that we need to be having?
I think the providers are overworked and, and have to stick to a 10-minute or a 15-minute appointment, and maybe in their minds they say, I don't have time to sit down and have a compassionate heart-to-heart with this patient. Or I just inherited the patient, I don't really know that patient, and I have to build a relationship in order to help that patient.
None of us are really taught these things very well, I would say. When I went through school, there was a big push on this empathetic care, and they had a whole class on that. I don't remember what they had some bogus name for it, and we're all like, yeah, we want to talk about pharmacology and get to the good stuff. And they're like, no, you need to know how to talk to people. That's what your job is. It's actually interacting with human beings and listening to them. So it was all these soft skills that we really, I think as a class, discounted, but I realize in hindsight, we need a hell of a lot more of that. Particularly around this issue, because, it's one thing to say, Mrs. Jones, I want you to use your inhaler. It's a different thing to say, I want to take away the only thing that's ever given you comfort on this planet.
Right.
That's very scary.
Yeah, definitely. Well, if you think of like a child with their security blanket and you yank that away, you have a tantrum. So if you were to do that with an adult that has an attachment to something,
We see
then
that.
it would definitely be the same.
And addiction becomes the attachment. So something that's universal about addiction is that you probably didn't have very good attachments early on. So your first real attachment is to your drug of choice. So instead of your parents or your family or other supporting roles, you find heroin, you find alcohol, you find something that soothes you, that keeps you company. It is your attachment. And moving away from that is very scary for people. And something that we do clinically is we actually transfer the attachment onto us, at least for a short period of time. And patients get very codependent. And I got a patient that I saw yesterday, she has 4 appointments on a weekly basis.
Yeah.
And I told her, I'm like, I need to space you out more than once a week. You know, like I'm not doing anything with your medications right now. You haven't had a drink in 2 months. I'm going to see you in 2 weeks. And, you know, and it was very hard for her. You know, I'm kind of tapering her slowly, but she has 4 contacts with us per week in our clinic.
Right.
So there is that transfer. We're out of time. So thank you guys for coming.
Super. Thank you.
Good conversation.
Plymouth County Public Health Agency, growing healthy communities.